Hello and welcome to today's webinar. My name is Joseph Krieger. Today we have Dr. Ryan Riggs from Tropocells, and he'll be discussing a very detailed analysis of current PRP technologies. So Dr. Riggs is a specialist in regenerative orthobiologics, and he's done a lot of research and sampled many PRP systems through the market. He's passionate about Tropocells PRP and believes it's one of the unique systems. He's also done a lot of work in looking at the next iteration or generation of PRP systems. So Dr. Riggs, thank you very much for being with us today. We look forward to your presentation.
Thank you, Joe, for that kind introduction. Like many members of the audience, I'm a practicing provider who tries to treat patients the best I can. When I learned about platelet-rich plasma, I was intrigued by the potential, but cautious about the effectiveness, because for every PRP study that showed a benefit, there was another study that showed none. Why is that? I went to a PRP workshop in 2014 and heard experts explain that the difference between these positive and negative studies was all in the formulation. I was taught that PRP isn't a drug, but more like a soup. How the PRP is prepared makes a huge difference. The funny thing was, although the experts note the difference between PRP formulations, they argued over what made PRP high quality and made PRP low quality. So they came up with this: not all PRP is created equal. And that's the part of my talk that I'd like to stress. There are many hypotheses out there, but what factors are the most important? Well, all of these have been looked at in the literature, and there's arguments on both sides of all of these. And it's hard to make sense of it all. So I've decided to make this my own personal quest, and I'm going to share a little bit of my journey with you in this webinar today. We do have time for a real deep conversation about these four, and the reason I picked these four is they seem to make the biggest difference. They're the factors that seem to really make a difference in the quality of PRP. So in order to prioritize these factors, you need to understand the purpose of PRP treatment. Essentially, by administering PRP to a target area, you want to harness the body's healing potential. Well, let's review what happens when we cut our finger down to the bone. First, we need to stop the bleeding, and then inflammation sets in because we need blood flow into the area to help recruit or to get all of the healing factors into the target area to do some healing. Then there's the recovery phase and the remodel phase. This is all coordinated by platelets, and PRP is platelet-rich plasma. It's essentially concentrating those platelets and putting them into an area to try to mimic this healing process. So the PRP healing process, you need a number of different things. You don't necessarily need hemostasis because you're not actively bleeding, but you do need to signal that an injury has taken place. You need to recruit stem cells into the area, get them to migrate into the target tissue, have them differentiate, and so that they can become, whether it's cartilage or bone or skin or muscle or tendon, and get them to proliferate and become that exact tissue. Platelets are the ones that play the primary role. So that's what PRP was invented for. Interestingly enough, it stands to reason that since the platelets play the primary role, the more platelets you have, the better. And that's what they looked at in this study back in 2002. This Hainsworth noted that when you increase the platelet concentration, you get a better response from the MSCs in looking at migration and proliferation of those stem cells. This was quoted by one of the experts named Marks in 2004. And interestingly, this study is the most cited study in PRP literature, with over 2,000 sites, 2,000 studies quote this exact study. So he has quite a following, and his conclusion was that platelet concentrates stimulate the migration and proliferation of MSCs in a dose-dependent manner. But what's interesting is, even though this was said back in 2004, there have been many different studies that have debunked that. They found that if it's too high, it doesn't work. They found that, it's intuitive that a higher platelet count yields more growth factors, but that hasn't been determined. And they actually see that you have a negative effect if it's too high of a concentrate. And so I went in and tried to find out why this is the case. And I think the easiest way to summarize it is, this isn't a slope where it's a dose-dependent manner. It's a stair step. You need to get a high enough dose of platelets to stimulate the recruitment, migration, and differentiation of MSCs. But once you do that, more isn't necessarily better. As you can see, this was followed out to a really, really high platelet concentration. And the slide before showed just this portion in through here, but it doesn't keep going up and up and up. It levels out. And this is looking at mobility and migration. And so I now think of this as, once you have enough platelets to do the job, it's going to do the job, and more isn't necessarily better after that. Now, I need to pause a moment here. This is one of my pet peeves, so I apologize for taking too much note on this, but I think it's important to talk about that. A lot of people are talking about platelet concentration. And the reason I have this orange juice over here is because orange juice is the same concentration whether there's a little bit or whether there's a lot. But the dose of orange juice is different. Well, I would love the PRP literature to actually talk about what's important. Concentration doesn't really matter. It's the dose that matters. Is it enough platelets to do the job? The concentration of platelets can be essentially manipulated just by removing more volume. And if you remove the volume, you can get a high concentration, but you don't have enough platelets to actually do the job. So platelet dose is one of the most important things if you get to a certain threshold. If you don't meet that threshold, it won't make sense. Please note that Magellan has one of the highest doses and Cascade has one of the lowest doses on this. And there happens to be a study that was in 2014 where they compared 7 different systems, and those two were on there. So we can look at the one with the highest concentration, Magellan, and the one with the lowest concentration. This is called cell fill, but it's the same as Cascade that I showed you before. In Japan, they just call it cell fill. And so when you look, I just want you to concentrate on the A graphs, because we'll go into this study a little more in detail when I explain some other things. But the difference is Magellan is high, cell fill is low, and sure enough, one of the growth factors that they measured, PDGF, you get a cellular response with one and not with another. But please notice that even though this is the highest, it wasn't the highest PDGF. So this supports my hypothesis that this is a plateau and a stair step, not necessarily a dose-dependent amount of platelets. So let's actually look at the biology of platelets. I think of platelets like foot soldiers. They're dormant in the bloodstream and swimming around in this state. Yet once they get activated by being put in an environment that shows injury, they activate and they form these pseudopods. And I actually have a little video that shows how that happens. When an injury is found, I'll just show it one more time. It forms these pseudopods and begins to activate. And once it activates, what actually happens is it recruits more platelets. They get sticky, and they release these growth factors that will stimulate a response. And so when you look at the cellular interactions of platelets, it all comes into view what is important about PRP. So they are delivering these growth factors in a very coordinated effort to promote healing. When it's time for hemostasis, they are releasing thrombin and platelet factor 4. And when it comes to the different phases of healing, a different soup that they are secreting, spices in the soup, if you will, and that will coordinate a different response from different cells. What's interesting is look how the platelet-derived growth factor is involved in almost all of the healing phases, but it's really dependent on the ratio between a certain growth factor and another, or the presence of other growth factors, or the signaling response from different cells is how the function changes. It's a very beautiful symphony of how we are designed as humans to heal. So in the healing process, again, we've gone over this. These are the things that need to happen, and we've talked about how platelets play a primary role, but it's coordinated by blood cells. So before we move on to figure out what the ideal formulation is, we need to know how these blood cells will interact with the platelets. So let's start with red blood cells. They are the most ubiquitous in the bloodstream. 95% of all the cells in the bloodstream are red blood cells. And when a platelet encounters a red blood cell, it thinks that there is bleeding going on, and so it will release the thrombin and the PF4 to create hemostasis. And you can see how that happens here. It will form a platelet plug. It's releasing the thrombin, and that's great because within seconds you can get a nosebleed to stop, for example. It's a beautiful way to go. You notice here how the thrombin interacts with the fibrinogen in the plasma to create fibrin, these little mesh fibers that will create a microenvironment over the site of injury. And within that microenvironment is where you can recruit the stem cells into the area. So that's how healing occurs. And the red blood cell role in healing is they will stimulate the platelets to release thrombin. They also will promote inflammation. But after that initial response, they inhibit other steps of the healing process. They've been shown to actually inhibit the recruitment, the migration, the proliferation, the differentiation of MSCs to the target area. If you think of a hematoma in your thigh after a big bruise, it inhibits healing rather than promotes it. It will delay the healing, and the hematoma has to be drained or absorbed before true healing can occur. That just shows that the RBCs are not good. So in the role in PRP, our red blood cells have no place in PRP because we don't need hemostasis and we don't really need inflammation as long as we can recruit the MSCs into the target area. So minimizing red blood cells is the next requirement for ideal PRP formulation. First is the platelets, having enough dose of the platelets, and the second is having low RBC count. So when you look at some common PRP systems, there are some that get a star for removing all the red blood cells. Notice that the top four are all gel barrier systems because they create a mechanical barrier that can stop the red blood cells from contaminating the final product. But interestingly enough, if you look at what I've shown you in earlier on, the platelet dose, the ones that are high in platelet dose happen to be low on the RBC contamination rate, because the higher the platelet count, the more RBC contamination you have. And the opposite is also true. When you have low RBCs, you also have you're lower on the platelet dose. So and we saw that Cascade already was a little too low of a dose to really stimulate a response. So the line may be somewhere up and through here. We don't know where that is, or I actually feel like I do, but I'll show you why I think so later on in the presentation. But red blood cells inhibit healing, and so they should ideally be removed from PRP. So the reason you get the high red blood cells is because of how PRP is processed. We use centrifugation, and that process will bring the denser red blood cells to the bottom of the tube. And all the good stuff is in this buffy coat area, the platelets and the white blood cells, which we'll talk about in a little bit. Those are all desired in PRP. And then there's not as very many platelets up here. So when we looked at Cascade, Cascade has a gel that actually has the density up and through here, and so you're only pulling this portion of plasma, and that doesn't have a high enough platelet count. So that's why the Cascade doesn't work as well. So if we could just get that without what I've done in my clinic, this is me trying to freehand the getting the buffy coat out. And as you can see, as I drop down the needle to the buffy coat layer, look what happens. The needle tip never touched the RBC layer, but because it creates a current, almost like a tornado, it just comes right up off of the layer and contaminates the sample. And then I end up with red PRP. So a lot of people will avoid this. So when you look at it under a microscope, when you have leukocyte-rich PRP, you still have plenty of red blood cells around. The purple dots are the platelets, the pink donuts are the red blood cells, and this is a neutrophil. This is just one example of a leukocyte-rich system. It was the harvest system. And if a platelet is around, what is it going to encounter first? A red blood cell. And so it's likely to inhibit healing. Whereas if you can pull from up more in the plasma layer, you can get a less RBC contamination. But the problem is you get less platelets. And so you still get, what are the platelets going to encounter on this slide? Well, they have just as much chance to find a red blood cell as they do a white blood cell. And so maybe the white blood cells we need to talk about a little bit. Before I do, I'll just show you the cascade. See how there's a lot fewer platelets on this slide than there were on the others. There are no white blood cells, but there are no reds. They did a really good job of removing all the reds, but they just don't have enough of a platelet concentration or platelet dose to stimulate that response. So let's now talk about leukocytes. We talk about leukocyte rich and leukocyte poor. So leukocytes have some bearing on PRP, don't they? Well, I want to split up white blood cells into two categories: granulocytes and mononuclear cells. That's based upon the presence of granules or the shape of the nucleus, but it actually fits in PRP quite nicely because the function of mononuclear cells and the function of granulocytes is quite different. Now, in the blood, neutrophils make up 60% of white blood cells, and eosinophils and basophils will make up less than 5% of those. So a lot of studies only talk about neutrophils, but they're talking about the entire granulocyte mix when they are talking about it. But for the setting of this, we're going to talk about neutrophils mainly. Lymphocytes are then the next biggest. There are many types of lymphocytes, and then monocytes, and we'll talk about both of those. So the function of a neutrophil is to fight bacteria. Well, this is good if you have an infection, but in the setting of PRP, are you really trying to fight an infection? No. You don't need inflammation as long as you can recruit the MSCs to the area, and this will have a catabolic effect by breaking down tissue, and that's what you don't want with PRP. So in the setting of PRP, you don't necessarily want neutrophils in your final sample. Contrast that with monocytes and lymphocytes. They are more like the medics who are doing a lot of cleanup through phagocytosis. They remove debris, and they also stimulate the platelets to convert into the recovery and the remodeling phase of healing. And so when you have a lot of monocytes along, it will stimulate the recruitment, migration, differentiation, and proliferation of MSCs, and will remove inflammation. But actually, if there's a lot of red blood cells and neutrophils around, the monocytes will continue to help with inflammation. So I like to think of it as a medic who can fight if the signal to fight is there, but once there's a wounded soldier, they immediately convert and try to do more of the healing and anabolic effect. So to summarize this then, the ideal PRP requirement number 3 is to minimize neutrophils because we want to avoid inflammation and catabolism. And requirement number 4 is to maximize monocytes and lymphocytes because they promote anabolism and enhance the response of stem cells in the healing process. So when you look at that, let's look at the common PRP systems and how they do on removing neutrophils. Eclipse and Tropicels, that happen to be from the same manufacturer, eStar. This is the cosmetic division of eStar, and this is the orthopedic division of eStar. But it's the same company. As you can see, there's quite a range. It's very hard to separate neutrophils from monocytes, and that's why most of the literature talks about leukocyte rich or leukocyte poor, because they don't think that you can separate neutrophils from mononuclear cells, but there are a few that do that rather well. And so I think we need to change our talk and talk about monocyte rich, neutrophil poor PRP, and that will be a little bit more accurate of what we're trying to accomplish. So in summary, poor quality PRP is not enough platelets to stimulate a response, a cellular response, or you have too many cells that promote breakdown of tissue and not enough cells that promote growth of tissue. And so if you can maximize platelets and mononuclear cells and remove red blood cells and neutrophils, you have a great PRP system. So all of these, if you just put all the anabolic factors on one side and all the catabolic factors on the other side, you can actually rank systems in a very poignant way. So I'd like to introduce the anabolic-catabolic ratio by adding up all the monocytes and lymphocytes in your final sample and contrast that with RBCs and neutrophils. And if you do a good job, you will approach 100% of the AC ratio. So let's see how current PRP systems do with that? Well, there's a huge setting apart here where Tropocells has an 89% anabolic catabolic ratio. That's huge. Look at all the competition besides Tropocells. I mean, we're only getting 5% anabolic effect compared to 90% anabolic effect. And so I went on a quest. I currently use Tropocells because of this exact reason, but I wasn't going to stop there. I wanted to prove to myself if Tropocells really is as good as they say they are. So I actually do my own slides. I've done hundreds of slides every time a PRP patient comes in. After we give them the PRP, I take one drop of the leftovers and take a look at it under the microscope. And I keep finding that Tropocells delivers exactly what it said it was going to. No red blood cells, and of the white blood cells that are there, they only have the mononuclear cells. It's a beautiful system. Just to contrast that, I got my hands on the Regen Lab, which is one of the closest competitors to Tropocells, but it still had quite a few red blood cells in it. And the amount of white blood cells, most of them are neutrophils. And so it still gave a catabolic effect, whereas Tropocells is all anabolic. Here's just a look. You can actually see with the naked eye the difference. This is a Regen Lab tube, and you can see how the gel barrier does not adequately remove all the red blood cells. You can see how there's some red blood cell contamination in through here. And Tropocells, there is a tiny bit of red blood cell contamination, but when you're drawing from up in here, the gel is a lot more pure, you can see, at sequestering the red blood cells. So how does it do it? I just wanted to show you what we're up against when we're talking about PRP. We want the cells in here. We only want the platelets, monocytes, and lymphocytes, but we don't want the neutrophils or the erythrocytes. So how can we separate those? Well, Tropocells created a gel that is right there. The density of the gel separates erythrocytes and neutrophils and keeps these. And so everything above this layer is all the good stuff, and everything below that layer is the bad stuff when it comes to PRP. So I think this really defines the next generation PRP. I did want to show, so this is just another one of my slides. I've done over 200 of these, and I consistently see this type of smear where I have to look for a red blood cell. It takes a number of different low power fields for me to find a red blood cell. And once I do, I usually find a monocyte along with it. This happens to be the worst slide I found in over 200 cases of Tropocells PRP, and I found 7 red blood cells in a low power field. Interestingly enough, this patient had an inflammatory flare 24 hours after PRP administration, which used to be, when I was doing PRP before I found Tropocells, that would be a norm. I would tell people that that's a sign that inflammatory flare was a sign that the PRP, that your body's responding to the PRP and it's gonna be good. But I found with how well Tropocells can remove the red blood cells, it actually doesn't have to be that way. That now my patients feel just fine after the PRP, and they only feel better. And that's because it has skipped the inflammatory phase of healing. So the big question then is does Tropocells deliver enough platelets? Let's go back and look at this Kushida study and see. Now, this is the only independent study I found of the TropaCells brand. And so I paid really close attention to this study. MyCells is the precursor to TropaCells. And so we can look at the Cascade and the TropaCells and the Magellan. Some of these others, they're only in Japan and you don't see them in the US anymore. But let's take a close look. So, does TropaCells deliver enough platelets? Well, they only drew, in this study, they only drew 8 mils of blood, whereas in Magellan, they drew 30. And again, this is concentration, so be careful. They're measuring the concentration. So the dose that Magellan provided of their PRP sample was 3 times this, because there were 3 mils of PRP in that sample. And so they were delivering a dose of 4.5 billion platelets, whereas the TropaCells brand, the MyCells, was less than 1 billion. So that's a huge difference, 4.5 versus 900 million. But you can see that TropaCells did really good at sequestering the red blood cells. There were still some RBCs in there. And the white blood cells, most of those were the mononuclear cells we were talking about. Cascade, we've already talked about, had a very low platelet count. This is actually below what whole blood concentration is. So by definition, this is actually a PPP sample, not a PRP sample, platelet poor plasma. But it did a great job of removing the red blood cells and the white blood cells. There were none. So then they looked at the growth factors. So here are the growth factors, just 3 common ones. You can see that Cascade did not really meet the mark at delivering a cellular response because the platelet dose was too low. But the TropaCells brand gave just as much of a concentration or of growth factors as did the Magellan, which was a 4.5 times more higher dose. The concentration of growth factors was the same. And that goes along with my plateau hypothesis, that once you have enough platelets to stimulate a response, more is not necessarily better. And so then you get the other growth factors as well, and you can see that TropaCells is right up in there with the others. There was no statistical significance between TropaCells and any of the other brands, even though they used less than a third of the amount of blood to get there. So it was very efficient. So TropaCells PRP is the best I've found, but I'm not done. I am looking for the best. The ideal PRP in my mind would have no red blood cells, would have a very high concentration of platelets, and the white blood cells that are around, I want them all to deliver an anabolic effect, not a catabolic effect. TropaCells is close, where we can't get rid of all the neutrophils yet, but I am hoping that this stimulates manufacturers of PRP to step it up. And now that we know what is needed to create what's called monocyte-rich PRP, where you have high monocytes, low neutrophils, no RBCs, and a high enough platelet count to make a difference. And if we do, PRP, in my mind, will skyrocket as far as the clinical uses, as far as the indications, because it will be that much more effective. So in conclusion, the ideal PRP formulation has been defined in the literature and actually is currently available in the TropaCell system. You could administer a platelet dose high enough to stimulate a cellular response. You're maximizing the anabolic effect by including the mononuclear cells. You're minimizing the catabolic effect by eliminating the red blood cells and neutrophils. And because you are consistently and persistently dedicated to get a better quality PRP, you will improve patient outcomes. I know I went over this very quickly, so I just wanted to give my contact information. If any of you listening would like to discuss any of the things I talked about, I do have the studies to back up some of my claims. So feel free to contact me, and I really appreciate this time. Thank you so much, Bob.
Dr. Riggs, thank you very much for that presentation. I think you did a great job at showing a lot of the nuances between the different PRP systems. And people hear words about white blood cell counts and different cell types, and they look at red blood cells and different layers. But I think what was interesting about what you showed was how the process itself, how the density gradients are created, and how that leads to a more simplified or better method of separation, and then really looking at the different constituents and how they play a role in inflammatory management and ultimately creating the healing cascade that's necessary in the ultimate function of platelets. So thank you very much for taking the time to break that down. It was great to learn about tropocells, and it's obvious that you have a high degree of interest and passion and experience in PRP systems, and we look forward to hearing more from you in the future.